They're going to be like, where is somebody? We are live. My apologies for all of you who've been waiting for 7 or 8 minutes for this show. This is the Healthcare Leadership Show with Marion Spears Carr, not the video technical show where we have all of our equipment always working. I just had to go to my backup camera. So my apologies for those of you who are waiting. If you're watching live, let us know. Today's episode is Coordination for Care, Survival Infrastructure for Rural Health. And my friend Selena Evans is joining us. Selena, introduce yourself, because you and I got into this conversation around rural health, and we're going to jump right in because we're running a few minutes late. And again, for those of you who have been waiting for the show to start, I had to go to my backup camera. We had a little power issue, so we're back up and running. Selena, welcome to the show. Please introduce yourself, and then we're going to get right into this topic because it's such a critical, important discussion that we're going to have that has been delayed for whatever reason.
That's okay. Better late than never. Marion, thanks so much for having me. My name is Selena Evans. I am a governance specialist. So I'm a lawyer. I am an organizational architect. I deal a lot with systems. I deal a lot with change. And I deal with a lot of, how can we govern, like the governance piece? How can we make choices collectively to better achieve our objectives? So that's the lens that I come from into the rural healthcare discussion.
Yeah, thank you for that. And if you're watching live, please let us know in the comments, or if you watch the replay, please let us know as well, because the whole idea of this show is connecting people like Selena to my network and beyond. And this topic is so important to me. For those of you who don't know, my name is Marion Spears Carr. I mentioned earlier, I run a company called Inflow Executives. We are a talent solutions, executive search, leadership development company. And one of the areas that we focus on tremendously is the rural health. I'm from rural North Carolina. I live in the rural mountains of Georgia. So rural health is such an important part of the work that we do, and also our lives. Selena, one of the things you and I talked about, and I talked about this in my promo for this show, is that when we think about survival of care in the communities that are losing care, the model, the critical access model, all the different healthcare delivery models that have been serving rural health for so long is failing across a whole bunch of different areas throughout the enterprise of healthcare delivery in those spaces. Share with our audience a little bit about kind of how you see the problem, and then more importantly, and this is what you and I really want to get into, is how you see change taking place in order to create that environment where we can sustain care, we can create opportunities for care. And you and I talked about this. There may be needs for some of the programs, some of the situations out there to go away and be replaced with something better.
Yeah, that may be true. Yeah, I mean, that may be true. My essential premise is that we may not know. Our funding structures, our decision-making structures, the way that that our institutions are set up are very fragmented. And this is not unique to rural healthcare. This is, endemic to the society that we live in. It is a problem. Rural healthcare is an ecosystem, and there's a lot to it. It's not just like healthcare as an institution, but it's about thriving communities. It's about food insecurity. It's about, heat resilience. There's so many different transportation and, so many different things. But the way that we fund these types of programs ends up putting things just sort of naturally into boxes and into, that reinforces the silos that we're trying to solve. Like, we talk a lot about care coordination in the healthcare space. Insurance companies will pay for this. Medicare pays for this. But it isn't just like a one-off thing. It can't just be a person. It has to be a system, the infrastructure, in order for organizations and philanthropies and communities to be able to connect, to be able to see the choices that are in front of them and to be able to decide collectively which ones are the most important is just incredibly fractured. And so I think that that's like really where we need to go. And I do see a lot of movement towards that space. But I think that the system keeps kind of pulling us back into this fragmentation. So I'll stop there and then we can go whatever direction.
I think that, all the directions. We've got all the directions. And so I do think from my work that I've seen, it is completely congruent with what you just talked about. There's this idea that regions or communities or states are burdened with this idea of it's your problem, you deal with it. And silent healthcare, as you know, and you've been working in it a long time as well as I have, maybe not as long, obviously not as long as I have, because I'm Methuselah when it comes to this business, but I've been around a minute. One of the things is healthcare is famous for being very siloed. Like the doctors are working on their problem, the doctor problems, the nursing groups are working on nursing problems, the large academic medical centers are all centered on let's build relationships with other academic medical centers and solve our academic medical centers problems in healthcare systems in the market, for-profit, non-profit. Everybody's got their own little thing that they're focused on. But when it comes to rural health, and when we talk about rural health, it is the majority of healthcare delivery in this country. For those of you who live in major cities and haven't been out of the city lately, there's a whole bunch of country out there, y'all. You know, my North Carolina accent's coming through, right? So I do see from your perspective that it's almost a mindset shift across healthcare enterprise and groups to say, wait a minute, this is a problem we have to solve collectively. We have to solve collectively. And so talk to me a little bit about how you see some of those barriers to being solid being broken down first, because it's, in my mind, if you think about it, like if I talk about rural health and I'm in an urban environment and the leader's like, well, we draw all of our patients from, right here in our city. That's not true. Right? If I'm having to have open heart surgery and I'm out where I live right now, I'm going to Atlanta, which is an hour and a half away by car, right? So talk about how we can start breaking down those barriers to it's not my problem, and how can we start moving in the direction of collaboration?
Yeah. Well, since you just said collaboration, I'll start there. So collaboration is full of wonderful intent. Yeah. And very, very important. But what it isn't coordination. Collaboration is, shared interests and wanting to chat with each other. Coordination is making sure that the system, is delivering against its purpose. So going back to the care coordination example, most care coordination is asking people or institutions to help, go across fragmented systems. What we need is coordination systems that reduce fragmentation from somebody's care journey. And in order to do that, you need to be able to design organizations that can hear and see that information, that can deliberately collaborate with other organizations or philanthropies or communities or whatever it happens to be, and act on that. There's disagreement in that. There's friction. There's different incentives. There's so many things. And it becomes really hard at the edges, but that's where people get lost. Like you, Marion, are in a great position that you can drive to Atlanta to be able to get your cardiac care. Transportation is a huge issue for many people in this country, or where to go or how to get the referral. But the referral, even just getting a referral is part of what we think of as care coordination, but that is not a care pathway. That still
No.
depends on, specialist capacity, the ability to get to the place where you're going, all of these different things. And so
Mhm.
my fundamental belief is that if we switch to thinking about these things more like capabilities that communities
Okay.
need to thrive, which would be different for all communities and regions
Mhm.
and everything. We need those decisions to be made in the communities. The irony is not lost on me that I'm here in Chicago talking about
Yeah.
rural healthcare, but essentially we need the communities to be able to navigate what is a very opaque and very fragmented system
Mhm.
where certain players have bigger voices. We need more of the voice to come into the rural communities. And that can be done very deliberately, and it needs to be funded. We fund products and we fund
Mhm.
solutions. But is that what this particular community needs? Is an app, like we think that an app, oh yeah, this app is really going to
Yeah.
help me. Well, that might not help somebody in rural. They might not want anything to do with an app. So that does not solve their
Absolutely.
care problem.
Yeah.
So that I kind of lost the question, but that's
No, that was that you answered the question because you answered the question in the fact that it's so complicated, it's so
Yeah.
complex
Mhm.
a problem that a lot of people around the country who are hearts in the right place, like you said, care, etc., have just kind of thrown up their hands because it becomes so complex. And that's one of the reasons why we changed the title of this discussion from connection of care or coordination of care to coordination for care, because there's a big difference with that particular word. It's around this coordination for care across the population. And by the way, I always give people in Chicago, I don't know about the other major cities in the United States, but I give people in Chicago a pass on their understanding of rural areas, because my family farm, where I spent some of my summers in corn and soybean, is in the central part of Illinois. I mean, you don't have to go very far south of Chicago and you're in corn and soybean until you get to Kentucky. So it is a rural. People don't get Illinois is one of the most rural states there is. Just because they have Chicago and Champaign and Bloomington Normal and Springfield doesn't mean that they're a big urban state. So I give you a pass. You know the rural area because you live right there at it. So there you go.
Well, thanks for the pass. Well, it's interesting. So I grew up in an ag town in the Central Valley in California, and so again, like close access, but you have a ton of rural farming communities out there that have very, very different needs from rural care in Georgia, like where you live. And since you're in Georgia, and my besties from Rome, I went and started looking at GREAT, at the Georgia initiative that's been funded whatever $1 million. And I was thinking that it might be fun for us to kind of talk about it in that context, because there I'm seeing like a lot of good stuff coming through.
Yes.
And there's obviously a lot of fun, like I think it's like $216 million like funded.
$216 million, yeah.
Yeah. So it's a great initiative. And so we have this like well-funded structure that we've created in this GREAT initiative. And they have like 5 pillars and 29, discrete initiatives and stuff. So where is the piece?
When you looked at that, what fired you up? Yeah, sorry, I'm interrupting, because we did a show on that earlier this summer, and that was what led me to this conversation. So I'm interrupting you, but I'm glad you're aware of that.
I'll talk forever if you don't interrupt.
Talk about that. Yeah, thank you. Talk about that, what you saw in that, because I think we had a panel discussion earlier this summer, on this very topic, and how Georgia is kind of, in some ways, been leading the way. But talk about what you saw in those initiatives, or what you saw in that process, that potentially would set a good example for every other organizations. And don't hold back. What's it missing? So let's talk about that. I think in my audience, a lot of my audience is in Georgia, so in the Appalachian region where I live. So what are your thoughts on that? I interrupted you, but I got excited, so my apologies.
No, I'm excited too. I could do this all day long. And I need to be interrupted, because otherwise I'll just talk. Okay, So we have this amazing funded structure, $216 million, 5 pillars, they even talk about knitting together, these different projects, and there's like 29 discrete projects. And that knitting together to me is like and the way that they've described it, because, these initiatives, they focus on many different aspects of care that I think have been neglected in many different regions of rural care in our country. So, you have, transportation and maternal care, and it's got all of these pieces that are really productive. And then they talk about knitting these things together to create a system. So I think that GREAT sees like the larger ecosystem in the way that they've structured it. But you have this funded structure, and you're putting that out there, and the funding's going to go through into these, buckets, and teams are going to be formed around the buckets, and they're going to have initiatives that they do. Everybody's going to be worried about scope creep, and everybody's going to be, all of these things. And so you start to like put these boundaries around each of these, and it's just natural. Every organization does it. So you put this structure in that sort of naturally starts to go towards silos, because that's a very human reaction to, dealing with complexity. We put things in buckets. And you start to reinforce the silos that are there, or create new ones, these kinds of things. So when you put a structure into complex systems, and we're dealing with complex systems, these are people, this is, systems of systems type stuff. If it stays as that static structure, if that strategy gets stuck, it is going to continue to mount the problems of silos, the lack of coordination. It could cause other issues. Certain things get funded, certain things do not. Certain geographies get more funding, certain do not. All of these things. So to me, like the connection piece needs to be very, very well thought out so that it can learn as you go. Like it can't just be funding a project. You have to be able to learn what is needed and adjust if necessary, And so those sorts of infrastructures need to be, and it has to be done deliberately, because if you don't fund that connective tissue, or if you only look at it from one centralized place, like they have like a governing board to be knitting this together, but that's not enough. You need to knit together from the ground up too. We need to engage communities so that they can make decisions that are right for their local community. That whole app thing, like, technology is awesome if it like completes a piece, a care journey, but people don't always want technology. We're talking about healthcare. We're talking about humans and relational importance of communities. So, I think that it gets a lot right, the GREAT initiative, but I worry that we're doing what we always do, and we put a big funded structure in that's going to reinforce silos.
Yeah, and that was one of the things we heard early when this whole process started with the Rural Health Transformation Program, et cetera, was that the pushback from the hospital associations, and I'm not speaking on behalf of any specific hospitals or association. I work all over the country, and obviously I'm from North Carolina, live in the mountains of Georgia, near the North Carolina border. So I'm not talking about anyone in particular, but I will hear, this is what we heard. All this is going to be a big money grant for vendors. It's all going to be focused on the vendor side. It's not going to be focused on transformation. It's all going to be focused on tech. Those are all those things that you hear when you hear about funding hitting the marketplace. That's what you hear, right? And you probably heard that as well. Yeah. So my question is how do we get these champions that we need? I'm going to push the other direction now. The champions we need from the community, from these organizations, et cetera, to the table to tear those silos down. In other words, how do we get the champions that are going to be vocal, are going to say, no, our community may not need a tech solution. Our community might need education to the fact that our population is healthy literate, right? They don't know what they don't know. It's not that they're dumb. They just don't know what resources are available, or where the ER is their only understanding of going to the doctor, right? They don't have any primary care. They don't like there's so much with those populations. How do we get the champions who can be a voice for those situations, those stakeholders, those organizations to the table and set aside the silo part? I know that's like this massive $100,000 million question, but what are your thoughts on that, Selena?
No, I mean, I think that is the question. And I think that that's the whole idea that we need to be learning through the process and engaging communities. Like you can't, listening sessions give you a snapshot in time, and they're like delivered by like people. Like think about, let's like talk about how this ends up working. So, you know, you have a community that is getting some funding, and you go and whatever organization is sponsoring this, you go and you do some listening sessions in the community. And it's a structured dialogue where, you know, everybody says, well, we need this, you know, this, and this. And the people who are putting on the listening session, you know, ask a bunch of questions that help support whatever it is they're building.
Right.
So it's really, really hard to find out what actually the community needs, especially if their mental picture of what healthcare is going to an ER that's 2 hours away, and that's the only way that they're going to get care. How long do they delay that care? How long do they, you know, how do they understand the interdependencies from the other, you know, stuff that they have in their life? So I think that it's I mean, I feel like it's an economy-sized question. If people feel like they have agency, feel like they have voice and feel like they are making decisions for their community, they will engage. They will start to understand it better. They will start to come up with their own mental pictures of what the possibilities can be. Because I agree with you, people aren't stupid. They don't have any trust, and they have for very good reason. They don't have trust. They've had resources extracting from the communities, going elsewhere, coming to Chicago, going to New York, going, you know, and wherever. Yeah. And in order to get people, like we have to me, these transformation initiatives are no good if they're not leaving a community better off in terms of being able to dictate their own future. Like we need decisions to be pushed down to local. And, you know, like, so my husband's family is from Lima, Ohio, and we were out visiting. Bell Fountain is this like real small town outside of Columbus a ways. And they've built this vibrant community. This woman, Sherry Duff, she's like freaking amazing. She owns a bunch of shops. Her sons invested back in their community, and they have this vibrant, like commercial oriented, like really cool community downtown. And I would wager a guess that their care situation, because they have this vibrant community and this connection to Bell Fountain as a place, this place-based pride and ownership and care, you're from a healthcare perspective, they're going to be miles better.
Yeah, I would
so
agree
like
with that.
the community investment is a piece of it too. And yet we do what we do. We put things in buckets and we separate healthcare from the larger, like vibrant community discussion. We, you know, kind of like investing in the community resources is a challenge. It's hard work that requires sustained effort. Australia is doing a cool thing where they're like making a big hay about rural health specialists, like care specialists. So it's like a main point of pride where they go in and they're the GP for a particular area, or they're the, you know, NP who serves a particular thing, and they're funding it. They're giving them, you know, like good money to be a part of it. And then those people are in the community versus a specialist that you go, you know, like whether you're going to Atlanta or Cleveland or whatever, that value, you know, goes elsewhere. And some of it needs to come back to the community. We need to preserve that value. In my opinion.
I think it's right on point. And I think you hit on it. The first word that you mentioned, the first word that stood out, your last answer is trust. in a rural community, be it wherever, be it Alaska, and I recruited up there, be it Montana, wherever, locals trust people who have committed to the local relationships and local culture, and that's where trust starts.
Yeah.
So to your point, I like the idea of what Australia is doing. That's incredible. We just had Tammy Hager on my show last week or 2 weeks ago. She's a physician recruiter, one of the top physician recruiting people in the country. And one of the things they've really specialized in is understanding the rural communities and getting physicians who not just have the skill sets to provide the quality care that's needed for that community, but have some connection tied to the community or have one reason to live there, which is what you're talking about. I love that idea. But building trust is so important. I mean, if you go to Western North Carolina and Eastern Tennessee, those families are a couple generations away from generations of or families who still don't trust the power companies because they came in and acquired land, Tennessee Valley Authority. And I'm not knocking TVA, but there's this history of distrust with the power companies up there because they seized land through eminent domain and all these different things. So there's this lack of trust. So when an outside entity, be it political or non-political, comes into a community, that becomes immediately we don't trust them. So I love the fact that you talked about that.
Well, and imagine the flip side of this too. We talk about technology a lot, AI for, I have quite a love-hate relationship with it, but for what it is, it's an amazing communication device. So there's a group called Cynefin. They're complexity researchers and whatnot, and they have a tool, SenseMaker, where they bring in narrative information from the community and show patterns of that information coming in, using AI to show the patterns. And so you can trace actual community set, not polling, not the people who select in, but you can actually see the patterns of what the community thinks that they need. And it isn't directed. I mean, it's always in some element. You mess with this anytime you're wanting to measure the system, you're messing with it. But at least you can then show no, this isn't our idea. This is your guys' idea. And this is how we're prioritizing funding. How cool would that be to do that? I mean, and you've got to. So there's a principle in complexity science. All action is local. If we're going to be able to do it, we're not going to be able to do it from centralized if we are going to disempower the local voices and the local action. They should be funded. They should be able to have value coming back into their community. There should be kickbacks from not kickbacks, not bad.
Yeah, I know what you're saying.
Benefits.
They need to see reap from some of it. Yeah.
I mean, you go to Atlanta and get your cardiac surgery. Why wouldn't some portion of that money that the insurance company paid for this come back into your local? We could, if you just start to imagine the different things that we could do if we really invested in the communities themselves, let them make their own decisions. There's so many cool things that we could do, but it's very hard because it goes against the way that we fund structures, the way that we source these things. And community is never going to be resilient just by getting outside resources. They need,
all that's 100%. And by the way, the cardiac example is totally, hopefully in my future, is completely hypothetical. I don't feel like I have to have heart surgery. For those of you watching me, me probably. You're probably he's probably on the verge of MI any time now. But no, that was a total hypothetical.
I hope not.
Wanted to make some clarity. I probably need to put some clarity. But to your point, I think that just providing an outside solution without the engagement of the community, without that, is it's going to fail.
Yeah, and things change, and the community is the ones who can sense that. If you set your strategy great, on high, and then you are deliberate and you just like go forward with everything you have, you're not going to be hearing the changes in the community necessarily. Like, any example, like, maybe some new like emergency service center got funded,
Yep.
like E-Resilient Center. Well, how does that change what like a particular community needs? It could change a lot. Like that is then
Yeah.
a place that could provide care and resources where people can start to know where they go when heat is extreme or if they lose power, like there's a lot of different cool stuff that we could do, but we've got to be able to be responsive and adaptive in the way that we govern these things. And that is all like coordination amongst different parties, and we just do not fund it.
Yeah, and that's the infrastructure, the survival infrastructure that we discussed.
Survival.
I'm sorry we got started late for all those who caught up with us, or if you're watching the replay. I knew this was going to go fast. I'm going to invite you to come back on the show again. We're going to open the can of worms and talk about some other solutions as well. But how can people connect with you, Selena? How can they connect with you, learn about the work that you do, and support what you're doing out there in the market?
Yeah, LinkedIn is the best way. I reserve more than half of my time for pro bono work. So like if people want to jam about any of these things or just get some ideas or whatever it is, I am always happy to do that. So LinkedIn is a really easy way to get a hold of me. I don't know. Yeah.
I'll drop your link into the comments after we get off the show. Selena, thank you so much for being on the show, but more importantly, thank you for the work that you're doing. This is, I sound cliche when I say this, but I've been in rural communities, not only as just as a citizen, but also in the work that I do in leadership development, executive search, et cetera, throughout my 35 years in the industry. And I know when I walk into a community hospital that the receptionist that's sitting there probably has had at one point, or maybe even currently, a family member that's going to come through that door any minute.
Yeah.
And I learned that very early. And this is really important. We've as a collective, if we actually forget the politics, forget all that jazz, if we really care about people, this is important work. So thank you for being on the show. And thank you for what you do. We will get you back on the show, and I promise my camera and my technology will not stutter for 8 minutes, and then we'll go from there. But thank you for being on the show. And any last comments for the audience before we go?
No, but while you were talking about the woman yes, of course, as you're talking about the woman in the hospital, like it's not about it's not necessarily about keeping the hospital open. It's about achieving the purpose that the hospital was there for, to provide care for real human beings, to be able to help them through very challenging times, to allow them, the ability to trust in the institutions around them. Like all of those things are so important. And we just need a little shift in perspective about how we think about this. And I think that we can really make some huge impact in that way. That'll actually serve.
Well, you just gave me the topic for our next discussion, because really when it comes right down to is access to care, and that the model of access to care that currently exists probably needs to change. To your point, maybe the hospital doesn't need to stay open. It needs to be remodeled in a way that it provides the access that's needed in a more efficient and financially sound, but also critical way. So maybe that's the conversation. So
and access is availability. Access is like willingness to use, the ability to use. It depends on all sorts of different things that ladder up to it. So I'm in for it. Let me know when.
That's a good one. Yeah, that's a good one. And I think that's the next iteration of this conversation. Thank you for being on the show, Selena. It's such a pleasure. Yeah, glad to be. For those of you watching the replay or watch online, please, or new while we were live, please let us know. Also, if you have topics that you would love to see the Healthcare Leadership Show cover, we will cover pretty much anything, because this is important discussions. Thank you for joining us today. Marion Spears Carr with Inflow Executives and the Healthcare Leadership Show. Have a great day.
Thanks, Mary.